Hello and welcome back to another episode of the Core Console RX podcast. My name's Mike Corvino. With me is Cole Swanson. How's everyone doing this week? Cole, how's your week going?
It's going well, man. Excited for another installment of Core Console RX podcast.
Yes, it's a real coming-of-age tale.
Mm-hmm.
So we're going to do things... We got a couple new, segments for you guys. For one, since we're so close to the end of the month, we're going to kind of recap on some of the new drugs that have come out and had FDA approval this month, just to make sure that everyone's aware of some of these new drugs. And then the other thing we're going to do is we're actually going to discuss a patient case and actually go through the case and then kind of go with some of our recommendations. And then we will upload the PDF file of the case to the website and coreconsolerx.com, so you can get a copy of that if you want to kind of follow along. So if you do want to do that, go ahead and pause the podcast and then go download it and come back. And hopefully, if this kind of works out well, we came up with this literally an hour ago. So if this works well, we are going to try to do this more often, and we'll have more elaborate cases and things like that. But this is trial run number one, so We'll see how it goes.
And if you want to go straight to it, probably coreconsolerx.com/podcasts will bring you there. And look for this one, click on it, and let's get rolling.
Sounds good. So what's your favorite drug that got approved this month?
If I had to choose one, I'd probably say Ozempic, one of the first ones of the month.
Yeah, I agree. Semaglutide.
Mm-hmm.
It's Novo Nordisk's once weekly GLP-1, and it actually was compared directly to Trulicity, dulaglutide, which for a while there was the only one of the once weeklies that met non-inferiority as far as A1C lowering when compared to Victoza, which is the market leader. So this one's been compared. It's actually a little bit better than Trulicity. I think it was the Sustain 7 trial.
Mm-hmm.
And so this is definitely a very, very good option. It's got strong weight lowering. We already have cardiovascular data with it from Sustain 6, Sustain 5, one of those.
Yeah.
But it does have cardiovascular benefit to it as well.
I think it was superior in that composite of non-fatal MI, non-fatal stroke, and cardiovascular death, where Trulicity's got the Rewind trials coming out?
Rewind's coming out next year.
Which I don't think look as promising as Ozempic, so we'll see.
And the others, have kind of been not so great. They've
Tanzium,
come out, Tanzium, Harmony Outcomes, and then there was the Excelsior with, I think it was called, with exenatide, extended release. So those have kind of showed that there's no cardiovascular risk, but there's no benefit either. So Victoza and Ozempic are probably going to be the two go-tos, and then maybe Trulicity as a secondary. But I'll tell you what, Novo Nordisk knows how to do some GLP-1s.
They're doing it all right. Yeah,
they're doing it all right over there.
You think it's going to be covered at all in the new year, Ozempic?
I think it'll take a little bit, like always. But
yeah, me too.
We'll see. And I mean, there's still some insurance companies that prefer Bydureon, and I don't understand that.
Yeah. But some still prefer Tanzium, I think, until I guess July when you're just not going to be able to give. Yeah.
But I don't. The insurance companies are always a couple years behind the actual science, so we'll see what happens.
Yeah.
What else do we have?
So there was also a new cream called Zepi, ozenoxacin. That was from Metametrics sometime early on in the month. Used to treat impetigo, so that's another new one that came out.
Yeah, that's the non-fluorinated quinolone.
Yes.
And it has coverage against Staph aureus and Strep pyogenes, so it's kind of cool.
Different than those fluoroquinolones, I suppose.
Yeah, get that fluorine out of here. So another one is the follow-on to insulin Lispro. It was Admelog. That was the name of it. So hopefully this will be another cheaper version of Humalog. So the follow-on, so it's not quite a biosimilar. We can't call it a biosimilar in this country. I think other countries will still lump insulins in with biosimilars, but this is they term it a follow-on, and it's not a true generic, but it considered equivalently effective compared to the Humalog.
So it's going to kind of act like the generic in practice in a way?
Yeah, kind of like Basaglar is doing with Lantus.
Yeah.
So hopefully this is another option for patients to bring prices down a little bit that are out of control on insulins.
Yeah, we also got Macamorelin acetate. It was approved on the 20th by Aeterna's Antares Pharmaceuticals, which I think is an awesome pharmaceutical name. But it was approved for the diagnosis of adult growth hormone deficiency. So it would help with that.
Very cool. Also, Xifi is another, this time it is considered a biosimilar to Remicade. This is their third biosimilar, I think, that's been on the market. I did a flash briefing on this one. I think the flash briefing is available on SoundCloud as well and iTunes. Just a quick recap, but one of the things just to mention with this is if you are unsure whether or not something is actually considered a biosimilar, make sure you look at the FDA's Purple Book as their reference. Mm-hmm. So like whereas Orange Book would compare generics and brands, the Purple Book is made specifically for biosimilars.
Awesome. Yeah. Also, Ropreza, Natarsadil. I'm getting all the fun ones to pronounce. Approved by ARI on December 18th to treat glaucoma and ocular hypertension. So that's going to be another eye drop used to help with that.
Yeah, and then one's the Rho kinase inhibitor, specifically for open-angle glaucoma or ocular hypertension. So what else do we have? We have, let's see, Stiglertro ergogliflozin is the new SGLT2 inhibitor on the market this month.
So what do you think of that one?
I don't know. I know they're what's the trial that they're doing they're looking at cardiovascular data.
It's called Vertis, VERTIS cardiovascular study.
So we'll see what happens when that comes out. I haven't seen any head-to-head trials with any of the other SGLT2s.
Yeah.
I wish they would, like GLP-1s did such a good job with comparing them. I guess depending on who you ask, the drug companies probably weren't happy, but they did such a good job with comparing them and giving them head-to-head data. We don't really have that with the SGLT2, so we kind of have to go based on side effects and stuff like cardiovascular data. So I still lean more with, if I'm going to use one of these, still move more with Jardiance.
Right, and they did some meta-analyses looking at the original three, but I took issue. It pretty much said that you can assume that the cardiovascular safety or efficacy is kind of a class-wide effect. I took issue with some of the things in the trial or in the study, but we can post that on the website. But yeah, other than that, there hasn't been anything randomized. So I'd like to see more with those.
Definitely, some people I know are worried now that Invokana or canagliflozin says that there's an increased risk in amputations, but I don't think that they've officially seen that as a class effect. But that is something to kind of keep an eye on.
Yeah, some of the ones we assume would be fractures potentially and genitourinary infections.
Yeah,
big things to look out for.
And ketoacidosis.
Yeah,
as well.
diabetic ketoacidosis.
It doesn't stem from elevated blood sugar. So that's kind of interesting. But so yeah, definitely some side effects with these guys, and I think they have their place. But I still prefer obviously the metformin and then GLP-1s.
Yeah.
What else do we have? There's an oral solution for Valsartan. Prexartan is the brand name for it. So that's going to be approved for hypertension and congestive heart failure. So that's on the market now.
It's actually pretty interesting because last month in the hospital we had a patient who couldn't take anything by mouth, and his peg tube was clogged, and they were trying to give him. Well, I guess that would have to go in a peg tube, wouldn't it? Still, so. Not really any IV ACEs or ARBs, are there? Okay, well,
yeah, it's still
wouldn't solve that
an
problem.
Oral solution, but hey, if you had the same patient and he couldn't take anything by mouth couldn't take tablets, but his peg tube worked, then I guess this
stick
would
it in
work.
there.
Yeah,
that would work.
So there you go. That's on the market now, and a couple other random drugs. Let's see.
Speaking of the renin-angiotensin system, there's Giapreza, which is the angiotensin 2. That they approve to increase blood pressure. So normally when you hear about the RAS system, you're thinking decreasing blood pressure, but they're actually doing the opposite and using it in septic or other types of shock to kind of as a pressor to increase. So that's pretty interesting.
Yes. I forgot about that one. Also, Lumify is the ophthalmic solution. It's bromonidine, but it's over the counter. So it's going to be used for eye redness is what they're actually have it labeled for. But yeah, it's over the counter now. So that's going to be available. That's one of those drugs that I've seen that's gone over the counter.
Yeah. So exciting stuff. You wonder why it's difficult to keep up with all the new drugs. They pop them out all the time, don't they?
Yeah, there's a lot of new ones. We didn't even cover all of them, but that's the majority of them.
Big ones.
This website I like is drugs.com, and you can just subscribe to new drugs as far as they have a news feed, and then you can pick new drugs or drugs that have they're in the pipeline, and they'll send you emails. That's one of the ways I keep up with it.
Yeah.
Cole, what do you use?
Yeah, that's what I use. And they've also got, if you're interested or as interested in trials and evidence as me and Mike, which you should be, you can sign up for the FDA new drug trial Snapshot, and it doesn't send it to you like the day the drug is approved, but kind of a follow-up in a couple weeks. It'll send you a snapshot of the study or maybe some type of landmark study that followed a GLP-1 or some other type of medication, and you can just run through it quickly. And if you're interested, you can go to the full trial and read the whole thing.
Yeah, that's a very good idea. I didn't think about that. Awesome. So that's the new drugs. What do you say? You want to tackle this case?
Sure, let's do it. So what do we got? We wanted to do an outpatient case. This is a pretty simple one, something that you're going to see all the time if you're in a clinic doing primary care, even if you're doing heart failure clinics, diabetes clinics, whatever. This is going to be pretty standard for patients in this elderly age group. So we've got LS. LS is a 76-year-old white male. He's coming to your clinic. He's a new patient for you, but he's doing a diabetes and heart failure follow-up. He just left his old primary care doc. So he's got a past medical history of congestive heart failure, HFrEF, with an EF of 30%. He's got diabetes. He's got hypertension. And he has a history of a CVA. And he actually has a little bit of left hemiparesis because of that, so a little bit of paralysis. So that's LS. He's taken a few meds. He's got Plavix 75, Pravastatin. He's on 80 milligrams, Carvedilol 12.5 twice a day. So he got the beta blocker. He's got lisinopril. So he's got an ACE doing 40 milligrams, Lasix 40 milligrams, all those once a day. He's doing metformin extended release 500. He's only doing that once a day, so a pretty low dose. And he's also taking glimepiride, we think. He didn't bring it in with him, but it's on his claims history, so we got to do a little more digging about that. So glimepiride 1 milligram once a day.
Sounds good. Where do you want to start?
So why don't we tackle his diabetes first?
Sounds good. So he is on, what did you say, metformin, 500 milligrams, just once a day?
Just once a day, also on glimepiride. So what's the first thing you want to do?
So it depends. His A1C was what, 7.4?
Yes.
So I obviously at this age, I don't know that I would really push his A1C lower. If he was higher than that and he was in the 8s, I would be a little bit more comfortable pushing his A1C lower. Obviously, the ideal metformin dose is 1,000 milligrams twice a day. We could consider that with him. His EGFR is 50, so he's still okay as far as being on metformin, even though he's a little bit elderly. But that's one of those things that if I was going to increase the metformin, it would be more hopefully to prevent some cardiovascular issues in the future,
right.
And
get a little bit of a legacy effect. But
yeah,
he is elderly, and I agree. Couple things to that. One, I totally agree with the A1C goal with his heart failure being as significant as he is.
Yeah,
I
wouldn't go much lower than that.
That's the primary, right? That's the primary issue with his A1C where it's at. Could we get him off glimepiride completely? And if we need more A1C control, can we just do the metformin?
Yeah, 100%. I mean, I'm not a fan of sulfonylurea unless the patient just has to.
Cost is an issue sometimes.
Yeah,
but
if the cost is an issue, absolutely, you got to do what you got to do. But if the person has insurance, if they have, this gentleman, if he's got Medicare Part D, I definitely would recommend using, if you needed something else, especially if you needed mealtime coverage, instead of using glimepiride, I would definitely recommend doing like a GLP-1 instead. I'm just not, there's too much risk with hypoglycemia, especially in elderly
and that's
patients.
probably the main thing is hypoglycemia. Some people mentioned that eventually there's kind of a cap on the benefit that you can get from sulfonylureas, 5-10 years, whatever. They say it kind of wears out the pancreas. But for this guy, take him off of glimepiride, and we can see if we need to, we could always increase the metformin, and it's honestly just as cheap as glimepiride. It's free at some pharmacies, and it's on the $4 list at most others. So not really a concern there. He is on the extended release, which is a little bit more expensive, but generally tolerable. So
yeah, and if we were going to increase it, I would say just add a 500 milligram tablet at night for a little bit, and then if he tolerated that, we could consider going up to 2 twice a day eventually, but definitely just adding the 1 at night with his evening meal and seeing how he does on it.
Sure. Yeah, so as far as diabetes goes, this guy's not too bad. Or as far as his A1C goes, how do you feel about a statin? He's on pravastatin 80.
So this one's can kind of go a couple different ways because of his age. He's over that 75 kind of age cap where we have recommendations on statin use. So we do have some data with the Prosper trial that looked at pravastatin in patients that were up to 82 years old. The issue with this gentleman, though, is he's actually had a stroke in the past. So in that case, we actually have data post-stroke with atorvastatin 80 when we saw positive outcomes in that from the Sparkle trial. So this is a hard one because based on his age, he still would have been accepted into the Sparkle trials. I don't believe they had an age cutoff in it.
Mm-hmm.
And atorvastatin 80, he could probably tolerate, and he may actually get some benefit. I think it really just kind of depends on what we think his life expectancy is, how well he's doing, kind of all of that put together, and looking at him as individually, and not just saying, in this case every time we would start atorva 80. There's plenty of clinicians who would be more than happy with keeping him on the Prava. So, I think that if I was going to switch him, I would be atorva, and I would jump to the 80 milligrams.
Yeah.
Because it'd be easier for me to drop to 40 than trying to start at 40 and then titrate up again. I've just found in my own personal experience, it's easier to kind of cut the dose in half than it is to double the dose.
Right.
So there's a lot of placebo effect with statins, statin intolerance.
Mm-hmm. Yeah, for sure. And I think the actual rates of intolerance in the studies are much lower. And you can do a lot of stuff, if this is off topic, but you can do a lot of stuff to kind of remedy it. Some people will give a statin a couple of times a week if they're really having bad myalgias. Pravastatin is one of the lowest risks. And interestingly, rosuvastatin is actually pretty low risk, even though it's considered a high intensity. I think that's a common misconception, is that the higher intensity it is, the more muscle pain you must have. Simvastatin is actually the worst for muscle pain. And rosuva is one of the lowest. I think Prava is probably lower than that. But so if they're having it with Lipitor, atorvastatin, can always try Crestor, rosuvastatin. So I think that's interesting.
Yeah, and you have to, if you think about whether the statin is lipophilic or hydrophilic statins, we would, like pravastatin and rosuva, we would think would have less penetration in the muscle, and we wouldn't have to worry about that as much in theory. And there is a meta-analysis out there that kind of shows that this does seem to play out in practice as well. So that's usually where just like Cole said, that's what I would think if someone's having these muscle pains and you've already lowered the dose, that's not helping. My next step would be to either switch to rosuva or Prava if they're on atorva or Simva or something. I would switch to one of the other two, or go every other day. Yeah.
And back to the dose, you might say, well, if you're that concerned about myalgias, which I'm not generally, why not just start at a lower dose and creep up? And he talked about that a little bit, but there's some evidence to just going straight for the high intensity instead of the lower. TNT trial compared atorva 80 versus atorva 10. It wasn't post-stroke. It was patients with CAD and hyperlipidemia. And they did have an age cutoff of 75, which of course this guy's 76. He's right there. But you might be able to lean on that a little bit if you to support just going straight for the 80.
Mm-hmm. Yeah, I agree. So I mean, I personally would like to see him do, especially if he's doing really well and in good shape and seems like he's really wanting to take control of his disease states and he's doing well. I would probably say a total of 80 would be fine and just kind of see how he goes. But it's one of those things whether or not you want to mess with it. What's his willingness to consider changing medications?
Mm-hmm.
So maybe case by case.
Maybe he had issues in the past with statins. Who knows?
Yeah.
So
that's why I like doing these because I never want to say blanket statements.
Yeah.
You'll always hear us say treat the patient specifically and not actually just follow the general guideline of how you do things. I'm not a fan of that. And
that doesn't mean, ignore evidence completely if this person doesn't want to take something for, not necessarily a valid reason. That's not, necessarily a good reason to switch to something like they don't want to take carvedilol and they have heart failure, so we're just going to do atenolol because that's what they've had before for hypertension or something like that. Anyways, speaking of that,
and I think in that case, just to kind of add on to that, like I would actually explain the data and show them the data, even though people think that patients can't understand that. Put it in the terms that they can understand and explain why you're doing things. And I think if you can say that I can reduce your chances of having heart attack or stroke or death just by switching over to this other medication, I think that you'd be hard pressed to find people who are like still unwilling to switch. But that's why I think trials and evidence is important, even when you're just speaking to a patient.
And that's speaking to patients, but even if you're a we'll say mid-level provider and you want to make a recommendation to your physician or whoever you're reporting to, or maybe they're asking you for your recommendation, you can always, if you can cite evidence, that's always very helpful. Cite a trial and tell them why I recommend this. So
100%.
Yeah.
So we said beta blockers. So what's our evidence-based beta blockers?
So we got 3 in HFrEF. We got carvedilol is one, bisoprolol also, and metoprolol, the succinate, so the long-acting version, which is Toprol XL is the brand name. So not metoprolol tartrate, which is I'm blanking on the brand name. Lopressor. So metoprolol succinate is the one that was shown to reduce mortality in heart failure specifically. And
if you look at the trials that had the cardiovascular outcome data with those 3 beta blockers, they always push the beta blocker of interest to their max to the max dose or as max that could be tolerated by the patient. So, in this example, this patient's only at 12.5 milligrams, assuming that he's not above 85 kilograms. 25 milligrams twice a day would be the max he could be on. So, his ejection fraction is still 30. So we may consider, as long as we're checking his heart rate regularly and it's not going too low, I would probably consider bumping him up to the 25 milligrams.
Right. And what else would you want to look at, especially with carvedilol compared to the other 2, to make sure it's okay before you increase it?
So monitoring his blood pressure, because carvedilol is a alpha beta blocker, you're going to, in theory, get a little bit more blood pressure lowering than you would with bisoprolol or metoprolol succinate. So you'd want to make sure you're monitoring his blood pressure, make sure it's not going too low. But if you had, kind of the opposite of that, if you had a patient who you want to add a beta blocker to because of heart failure, but his blood pressure is a little bit low, then metoprolol succinate or bisoprolol would probably be a better option. So keep those in mind. And then you'll also hear an argument of, well, carvedilol has been proven better than metoprolol succinate. If you hear, that's referring to the COMET trial. The issue with COMET was they compared carvedilol to metoprolol tartrate, and they only used metoprolol tartrate 50 milligrams twice a day, if I remember correctly.
Yeah, it wasn't a full dose.
Yeah, well, the dose of metoprolol succinate that's been shown to be effective is 200 milligrams from Merit HF. And so COMET, realistically speaking, if you were to get a true comparison, even though this isn't really based on evidence, you would need metoprolol around 150 milligrams total daily dose of the tartrate to equal 200 milligrams of the extended release, the succinate. Reason for that is you need a higher concentration of the succinate because as it's metabolized by 2D6, it's going to have longer to chew up the drug and metabolize it. So you need a higher concentration to get through that first pass metabolism.
Right. So it's roughly a 1 to 1.5, comparison.
Yeah. So I always think like 150 milligrams of tartrate equals 200 milligrams of succinate. That's how I kind of think about it. And I've actually seen, there was an older cardiologist one time, and he actually had someone on metoprolol tartrate 50 milligrams, but was dosing it 3 times a day. And I know we had talked about this, and we were kind of concerned as to why he was doing that, but it's actually, in theory, kind of equivalent to the evidence-based dose. So it's kind of interesting.
Because of the half-life is not necessarily 12 hours. It's like 6 to 8 or something like that. Yeah, interesting.
So the other thing is the lisinopril. So he's on lisinopril, and that's maxed out, which is good.
40 milligrams.
Atlas trial, we saw that the maxing out the ACE gives better benefit than keeping them at a lower dose. So that's another one that we see oftentimes not pushed to where it can be as ACE inhibitors.
Right. And that's one thing about heart failure is that we actually have not just goal medications we want people to be on, but goal doses we want to reach to see the most benefit, because that's what's evidence-based. Not for all the medications, but for a fair amount of them that you're going to put people on. For
sure. What about Entresto for this guy?
I think that would be an option for him. So his EF is 30. Entresto, we saw in the Paradigm HF trial, they compared that to enalapril. We saw mortality benefit compared to an ACE. Granted, it wasn't the full dose of enalapril, but the evidence is pretty compelling to say that it could be first line over an ACE or ARB in heart failure. The new guidelines are recommending that, but it's still relatively expensive. Price is coming down, but that's definitely a hindrance to most people, I would think.
Yeah. The other thing to make sure, if you do have a patient that is a candidate for Entresto, which if you're not, hopefully you're familiar with that at this point, but if you're not, it's a fused molecule of sacubitril, which is a naproxen inhibitor, and Valsartan, which is, hopefully you're familiar with that, it's an ARB. And basically one of the higher risks that we have with this is angioedema, and it's actually more so because of the sacubitril component, the naproxen, there's a little bit higher risk than even just with an ACE, because we always think of angioedema with ACE inhibitors, but Entresto does have a risk of it. So one of the things that you have to do is, if you are switching a patient from an ACE to Entresto, you have to have a 36-hour washout period, and this is really, really important. I've actually dealt with this myself, where a patient came in to the retail pharmacy and was getting his prescription, or I guess he dropped off a prescription for his Entresto, and I was there doing MTM that day and explained kind of what the drug was, because it had just been on the market for like a month at that point. And at that time, I told the pharmacist who was about to dispensing the medication to put a note on there, because currently the patient had been taking enalapril. Told him to put a cap on a consult on there and explain that the patient needed to basically stop this ACE inhibitor for 36 hours before going on the Entresto. Well, like 6 days went by, and that pharmacist called me and said that the patient's wife had come in, and he had been given samples at the office from the physician who wrote the prescription, and I don't know if it was on his take-home paperwork and he didn't read it, or if the physician just didn't tell him, or the nurse didn't tell him, or who it was, but he was not informed of this 36-hour washout period, and he took his enalapril with the Entresto and had angioedema. So now we run into a situation where one of the contraindications to Entresto is a past case of angioedema. So we potentially cost this guy medication that is very effective at reducing not only hospitalizations but mortality because of a failure to consult. So that's super, super important. I know it's a long-winded story, but super important that we are educating patients on that 36-hour washout period.
Yeah, for sure. And patients, to be indicated, ultimately have to have shown to have tolerated an ACE, right?
Mm-hmm.
Yeah.
Typically, that's how they did. That's how they set it up in the trial.
Right, that's how they set it up. And you mentioned it was a male, but the patients at highest risk for angioedema are actually African American females. So that's who you definitely want to look out for. But I mean, in any patient taking Entresto, you want to make sure that that's addressed.
Mm-hmm. Absolutely. What else do we have for this patient? They're on daily Lasix for just edema.
Is he going to get mortality benefit from that?
No, I mean, not necessarily mortality benefit. He would more get symptom relief. But the other thing to keep in mind too, and some of you may have seen this if you're not familiar with it, but you may have run into this at some point. Eventually, a lot of times you'll see patients get to a certain dose of Lasix and it's just not effective anymore. And there's something we can actually add on to Lasix that will work in kind of a synergistic way. Metolazone, which is a thiazide diuretic. And most thiazides work in the distal convoluted tubule of the kidney, but metolazone actually has activity in the proximal convoluted tubule as well. And so you kind of shuttle some of those electrolytes down into the loop of Henle, so the Lasix or whatever loop diuretic you're using works a little bit better. So in heart failure patients specifically, you will see this combination of usually it's furosemide along with metolazone.
Yeah, and it generally is very effective. And I've seen you don't usually use it with every dose of Lasix. You don't usually use it every day. I've seen patients just use it once a week, and they'll call it their booster, is what they'll say. But it can also be used 3 times a week, just depending on whatever the nephrologist wants.
Yeah, and you definitely have to be careful with it because you can bottom people out with blood pressure and dehydrate them and all that. So you definitely would be careful with it. But if you do see it, that is an option out there, and why they're using it.
So we got this guy on Crevedolol. We got him on an ACE. He's on Lasix. Is there anything else he needs or could? I guess what would be the next step for heart failure?
So this gentleman, he's blood pressure is 155/95. So there's a couple things we could do if we were looking more on the heart failure side of things. We could talk about spironolactone. The issue with that is he is older. Depending on, spironolactone is really effective at lowering systolic blood pressure. I mean, you can think about 20 points systolic in some cases with spironolactone. So if you look at the RAILS trial for heart failure, we definitely have good data with that with spironolactone, and that's kind of where that 20 points blood pressure drop comes from. But that's something to be, because of his age, we have to be cautious with it. We're not dropping him too low, and but that is something we could definitely consider. What else are you thinking?
Spironolactone is the biggest one I'm thinking. I don't think we would look into Aberdeen or anything with this guy.
No, I'm not a fan of Aberdeen unless they just. I'm not a fan of Aberdeen.
No.
There's very few people that I think would be all that beneficial with.
Agreed.
What about if we were going to target more of the hypertension side of things? What would you do?
I mean, you could add on a diuretic, or you could add on calcium channel blocker potentially.
Which diuretics would you do?
Like indapamide.
Yeah, indapamide. Yeah, I agree with that for sure. Or clothalidone. Either one of those, I would like. Indapamide, we have evidence with the HIVET trial, which was patients 80 to 100. So this guy's actually almost the age where he would qualify for that. Clothalidone, we have evidence with ALHAT and also with SHEP. And then indapamide, we have the Progress, I believe, which it might have been post-stroke actually. So Cole will look at that real quick for me. Don't quote me on that yet, but I think it might be post-stroke, which may even fit this guy even better. But outcome data with both of those thiazides, so I agree with that for sure.
It was post-stroke.
Was it?
Yeah.
Yes, winner.
Awesome.
What about let's talk about his potassium.
Yeah.
So either way, regardless of which decision to.
Right. I was gonna say if we're considering adding on spironolactone, he's already on an ACE, then first lab you're probably gonna look at is his potassium. So we actually did get one on this guy. So his is 4.2, so within normal limits. And there is a cutoff. So if you get that back for spironolactone, you want it below 5, right? And an ACE, if you're gonna start an ACE, you want it below 5.6.
Yeah.
So that's what you're looking at there. And there's also, if we were to add on a diuretic, what would be concerning there? You mentioned the Shep trial.
Yeah, so like the Shep trial was involved chlorthalidone and actually had a add-on of atenolol, believe it or not. But one of the things they noticed with the patients that received chlorthalidone was that if the patient's potassium, this was done in a secondary analysis, but if the patient's potassium was dropped below 3.5, they actually lost all the outcome data, like benefits of chlorthalidone. So the mortality benefit was gone. And so there's going to be some people based on that would actually aim for a potassium of 4, just to be on the safe side that you're not going too low. This guy's on Lasix. He's on now a thiazide diuretic. So you'd want to make sure that you are monitoring that, because you don't want to have a guy on an evidence-based thiazide diuretic and then have it not be effective.
Right. And a lot of times with pretty much anyone with any sort of heart condition, you could, if you're above 4, you're pretty much golden. But of course, generally 3.5 for normal people would be the lower limits of normal.
Yeah.
So yeah, that's his heart failure. Got anything else for that?
No. About aspirin for this guy?
I don't think so. He's
No.
already on Plavix.
Yeah.
So what would adding on aspirin probably do?
Nothing.
No.
The match, I believe.
Mm-hmm.
Match trial, they added on aspirin with to patients who were already on clopidogrel and didn't see a difference.
Didn't see a benefit. They actually saw an increased risk of bleeds, potentially severe bleeds. So
yeah, so I would not recommend an aspirin, even though he's had an event. Even if he hadn't had an event, the sweet spot for aspirin now, according to the U.S. Preventive Services Task Force, is 50 to 70 is kind of the sweet spot. Really, 50 to 60, and then as long as the benefit outweighs the risk, from 60 to 70 as well. But after 70, a lot of times the benefit doesn't outweigh the risks. So you really have to take the aspirin for, is it 10 years?
Yeah. So they want you to have a
the
10-year life expectancy to really benefit from it, because it takes that long to see the benefit.
Yeah, and it can give you cardiovascular benefits, but it can also prevent colorectal cancer as well, as another thing. So aspirin definitely has its place, even in primary prevention, but I wouldn't recommend it in this guy.
Yeah, main place we're really thinking dual antiplatelet is post-stenting, right?
Mm-hmm.
So not necessarily this guy, just history of CVA.
Yeah. Okay, anything else with him?
That was pretty much it. Maybe immunizations. We could run through those really quick.
Yeah,
right?
we can do that real quick. So let's just say hypothetically, since we didn't include this in the case, he has never had any immunizations.
0.
Then this year it's getting later in the year, but I'd still try to give him a flu shot.
Go ahead and give it.
We have three flu shots that he could get, or I guess 4 technically if you want to count quad. But we had the standard flu shot, which several different brands that make that. Then we also have Fluzone High Dose, and then Fluad is the other ones of those 3. Which ones do you recommend?
I'm trying to remember. We don't like Fluad, right?
Yeah, I'm not a fan of Fluad, and I think the reason for that is if you look at the head-to-head data, it was only non-inferior to the regular standard flu shot. It didn't meet the criteria for superiority. And because it's got that adjuvant in it, which they use this squalene oil emulsion, it actually can cause more localized reactions, things like that. And so I'm just not a fan. Whereas Fluzone High Dose has been compared. The trial I think was done in 2014, but it doesn't have a cool name, so it's hard to remember. But that one was compared to standard, and it actually was statistically different. Now the number needed to treat was 218. So it's a little bit, whether or not it's all that effective. It depends on your point of view, I guess. They did do a cost-benefit analysis and showed that it is actually cost-benefit positive if you were to get the Fluzone over the standard, but the CDC still hasn't made a recommendation that I've seen.
There you go. So it actually does matter which flu shot you get. How did that do this year? I hear that people weren't too happy with it.
Yeah, I don't think it's covering very well this year.
You should still get it, though.
Still get it, yeah.
Get your flu shot.
It's not going to hurt you.
It's covered almost all the time.
It's not going to hurt you despite what people may say on Facebook.
Yes.
But, so flu shot, and then if he's never had any vaccines, Prevnar 13 would be first, and then a year later, because of insurance, we have to get it billed.
But you could get it within 8 weeks?
Yeah, technically you can't get it within 8 weeks, but they've changed the guidelines now to say a full year just based on CMS and making sure that patients are having it covered. But so then he'd get Pneumovax 23 a year later after Prevnar. What else?
Well, he could get Zostavax, or better yet, could get Shingrix. How about that? Yeah. So we don't have that yet. We're getting it next month. So I would just wait.
Yeah, I would hold off on it because if they do get Zostavax, according to the data anyway, if you're going to follow that, you'd really have to wait about 5 years to give them the Shingrix, and it's so much more effective. This guy's getting approaching 80, and when you hit 80, you're looking at about an 18% efficacy with Zoster. So I wouldn't even really consider Zostavax with this guy.
And Shingrix is 2 doses, right?
It is 2 doses, yeah. So this 2 doses, especially if it's really pretty. It's a little bit more expensive, but pretty comparable in cost.
I think it's worth it.
I
had a guy
100%.
come in yesterday with shingles, and just hearing about it again, it's terrible.
Yeah, so I would definitely any family member of mine would recommend Shingrix over Zoster. Plus, it's a killed vaccine, so
no more of that live stuff.
Yes.
Cool. But, also, use a Tdap.
Yeah, if he hasn't had tetanus in a while, then
or
Tdap or a tetanus booster at least. And it depends on if he's checking. He's not really injecting insulin, so his kidney function is okay. But if he was looking at his kidney function was declining, and he was looking at hemodialysis, we could consider Hep B vaccine series if he hadn't had that. But again, it kind of just you'd have to weigh his life expectancy and everything else, and with what we were going to vaccinate him with, and if he's even willing to get him in the first place.
Right.
But yeah, that's the first case. That's case number 1.
It's case numero uno.
Numero uno. So hopefully we'll gather some feedback from some of you and figure out whether or not you like that or not.
Yeah, let us know if you thought we were wrong. If you treat him different, tell us.
I would actually really like that too, because I'd like to get more conversations going. I'm neither one of us are infallible by any stretch of the imagination, so I'm actually wrong a lot. So no,
Mike's the data king, though.
Nah, I don't know about
Throwing
that.
them all out
I just
there.
repeat what other smart people have actually said. But I think that I would really, really encourage you guys to give us some feedback and leave comments if you prefer different strategies and kind of get the conversation going.
Yeah, and if you want to break down any of those specific trials, we can potentially provide that. Also, check out that coreconsultrx.com/podcast. We're going to post pretty much any trial we talked about, and maybe if we found a good summary, we'll post that on there too with the podcast. Hyperlinks, just click on them and you can learn more. So check that out.
Yeah, that's a good feature. I actually didn't even realize Cole was doing that until just recently, and
being
I went on the website and I was like, oh wow, this is a great idea. Wish I would have had this. But so that's really helpful. But yeah, that's about it. So make sure you give us a follow or a like on all the major social media platforms, and make sure you subscribe to us on iTunes or SoundCloud. And if you prefer the video side of things, definitely subscribe to the YouTube channel. And I'm always interested to hear what kind of feedback and also ideas that you guys have. Or if you're interested in being like a guest, if you think you have a really interesting job or history or whatever it may be, reach out to one of us.
Or even if you're not that interesting.
Yeah, because
we'll
we're not
still
that
have
interesting,
you on.
and we're still doing it.
Yeah, we'll make it interesting.
At least they haven't told us we can't yet. So, but yeah, definitely reach out to us, email or any of the social media platforms. You can reach us at that and let us know. And yeah, until then, we'll see you guys next time. Thanks for listening.